Hello and welcome to the Coding Corner, Medical Coding Education. Today we are covering chapters 20, 21, and 22 of the ICD-10 chapter-specific coding guidelines. My name is Kristen Robinson. I am a coder, auditor, and educator, and let's get into it. First up, we have chapter 20. This is for external causes of morbidity. These are your codes V00 through Y99. So, a little bit of backstory about our external causes for morbidity codes. These should never be sequenced first or listed as a principal diagnosis. External cause codes are intended to provide data for injury research and evaluation of injury prevention strategies. These codes capture how the injury or health condition happened, or the cause, and the intent, unintentional or accidental, or intentional, such as suicide or assault, the place where the event occurred, the activity of the patient at the time of the event, and the person's status, such as civilian or military. There is no national requirement for mandatory ICD-10 CM external cause code reporting, unless a provider is subject to a state-based external cause code reporting mandate, or these codes are required by a particular payer. Reporting of the ICD-10 CM codes in Chapter 20 for external causes of morbidity is not required. In the absence of mandatory reporting requirements, providers are encouraged to voluntarily report external cause codes as they provide valuable data for injury research and evaluation of injury prevention strategies. So now let's get into our general external cause code reporting guidelines. Number 1, use with any code in the range A00.0 through T88.9 and Z00 through Z99. An external cause code may be used with any code in the range that was just previously mentioned. Classification that represents a health condition due to an external cause. Though they are most applicable to injuries, there are also valid for use with such things such as infections or diseases due to an external source, and other health conditions such as a heart attack that occurs during strenuous physical activity. Number 2, external cause codes used for length of treatment. Assign the external cause code with the appropriate 7th character, initial encounter, subsequent encounter, or sequela for each encounter for which the injury or condition is being treated. Most categories in the Chapter 20 have a 7th character requirement for each applicable code. Most categories in this chapter have 3 7th character values: A for the initial encounter, D for a subsequent encounter, and S for sequela. While the patient may be seen by a new or different provider over the course of treatment for an injury or condition, assignment of the 7th character for external cause should match the 7th character of the code assigned for the associated injury or condition for that encounter. Number 3, use the full range of external cause codes. Use the full range of external cause codes to completely describe the cause, the intent, the place of occurrence, and, if applicable, the activity of the patient at the time of the event, the patient's status for all injuries and other health conditions due to an external cause. Remember, we want to assign as many external cause codes that are necessary to fully explain each cause. If only one external cause code can be recorded, assign the code most related to the principal diagnosis. Selection of the appropriate external cause code is also important. Okay, remember that external cause codes are guided by the alphabetic index of external causes by the inclusion and exclusion notes in the tabular list. An external cause code can never be a principal or first listed diagnosis. Seventh character combination codes also are applicable. Combination external cause codes are certain external cause codes that have combination codes that identify sequential events that result in an injury, such as a fall, which results in striking against an object. The injury may be due to either the event or both. The combination external cause code should be corresponded to the sequence of events regardless which caused the most serious injury. And lastly, for this slide, no external cause code is needed in certain circumstances. So, external cause codes from Chapter 20 uh, are used in certain areas but not used in other areas. So if the intent is included in the code from another chapter, for example, T36.0x1, poisoning by penicillins, accidental or unintentional. So next we're going to talk about place of occurrence. Code category Y92 for place of occurrence of external cause are secondary codes for use after other external cause codes to identify the location of the patient at the time of injury or other condition. Generally, a place of occurrence code is assigned only once at the initial encounter for treatment. However, in the rare instance that a new injury occurs during hospitalization, an additional place of occurrence code may be assigned. No seventh characters are used for Y92. Do not use place of occurrence code Y92.9 if the place is not stated or is not applicable. So for activity codes, assign code from category Y93 for the activity code to describe the activity of the patient at the time of the injury or other health condition that occurred. An activity code is used only once at the initial encounter for treatment. Only one code from Y93 should be recorded on the medical record. The activity codes are not applicable to poisonings, adverse effects, misadventures, or sequela. Do not assign Y93.9 unspecified activity if the activity is not stated. A code from category Y93 is appropriate for use with external cause and intent codes if identifying the activity provides additional information about the event. So now let's talk a little bit more about place of occurrence, activity, and status codes when used with other external cause codes. When applicable, place of occurrence, activity, and external cause status codes are sequenced after the main external cause code or codes. Regardless of the number of external cause codes assigned, generally there should be only one place of occurrence, one activity code, and one external cause status code assigned to an encounter. However, In the rare instance that a new injury occurs during hospitalization, an additional place of occurrence code may be assigned. If the reporting format limits the number of external cause codes that can be used in reporting clinical data, report the code for the cause or intent most related to the principal diagnosis. If the format permits capture of additional external cause codes, the cause or intent, including medical misadventures of the additional events, should be reported rather than the codes for the place, activity, or external status. Multiple external cause coding guidelines. More than one external cause code is required to fully describe the external cause of an illness or injury. The assignment of external cause codes should be sequenced in the following priority. If two or more events cause separate injuries, an external cause code should be assigned for each cause. The first listed external cause code will be selected in the following order. External cause codes for child and adult abuse take priority over all external cause codes. For additional information for this, you can see section IC19 for child and adult abuse guidelines. External cause codes for terrorism events take priority over all other external cause codes except child and adult abuse. External cause codes for cataclysmic events take priority over all other external cause codes except child and adult abuse and terrorism. External cause codes for transport accidents take priority over all other external cause codes except cataclysmic events, child and adult abuse, and terrorism. Activity and external cause status codes are assigned following all causal or intent external cause codes. The first listed external cause code should correspond to the cause of the most serious diagnosis due to an assault, accident, or self-harm following the order of hierarchy we just listed. Lastly, for this page, child and adult abuse guidelines. I don't know why I cannot remember to say adult on all of these. Adult and child abuse, neglect, and maltreatment are classified as assault. Any of the assault codes may be used to indicate the external cause of any injury resulting from the confirmed abuse. For confirmed cases of abuse, neglect, and maltreatment, when the perpetrator is known, a code from Y07, perpetrator of maltreatment and neglect, should accompany any other assault codes. For additional information on this, you can see section IC19, adult and child abuse, neglect, and other maltreatment. For unknown or undetermined intent guidelines, if the intent, accident, self-harm, or assault of the cause of an injury or other condition is unknown or unspecified, code the intent as an accidental intent. All transport accident categories assume accidental intent. Use of undetermined intent. External cause codes for events of undetermined intent are only for use if the documentation in the record specifies that the intent cannot be determined. For sequelae or late effects of external cause guidelines, number one, sequelae external cause codes are reported using the external cause code with the seventh character S for the sequela. These codes should be used with any report of a late effect or sequela resulting from a previous injury. For additional information on this, see section IB10 for sequela or late effects. Number two, sequela external cause codes with related current injury should never be used with a related current nature of injury code. Number three, use of a late effect external cause code for subsequent visits when a late effect of the initial injury is being treated. Do not use a late effect external cause code for subsequent visits for follow-up care. For example, to assess healing, to receive rehabilitative therapy, or other instances where the injury, when no late effect of the injury has been documented. Next up, we have terrorism guidelines. Number one, when the cause of an injury is identified by the federal government or FBI as terrorism, the first listed external cause code should be a code from category Y38 for terrorism. The definition of terrorism employed by the FBI is found at the inclusion note at the beginning of category Y38. Use an additional code for the place of occurrence from Y92. More than one Y38 code may be assigned if the injury is the result of more than one mechanism of terrorism. Number two, when the cause of an injury is suspected to be the result of terrorism, a code from category Y38 should not be assigned. Suspected cases should be classified as assault. And number three, assign code Y38.9 for terrorism secondary effects for conditions occurring subsequent to the terrorist event. This code should not be assigned for conditions that are due to the initial terrorist act. It is acceptable to assign code Y38.9 with another code from Y38 if there is an injury due to the initial terrorist event and an injury that is a subsequent result of the terrorist event. Last up for this slide, we have external cost status codes. A code from category Y99 for external cause status should be assigned whenever any other external cause code is assigned for an encounter, including an activity code, except for those events noted below. Assign a code from category Y99 for external cause status to indicate the work status of the person at the time the event occurred. The status code indicates whether the event occurred during a military activity, whether a non-military person was at work, whether an individual, including a student or volunteer, was involved in a non-work activity at the time of the causal event. The code from Y99 external cause status should be assigned when applicable with other external cause codes such as transport accidents and falls. The external cause status codes are not applicable to poisonings, adverse effects, and misadventures or late effects. Do not assign a code from category Y99 if no other external cause codes, cause, or activity are applicable for that encounter. An external cause status code is used only once at the initial encounter for treatment. Only one code from Y99 should be recorded on a medical record. And lastly, for Chapter 20, do not assign code Y99.9 for unspecified external cause status if the status is not stated. Next, we have Chapter 21. This is for factors influencing health status and contact with health services. This is for Z00 through Z99. This chapter has specific guidelines that provide additional information about the use of Z codes for specific encounters. The use of Z codes in any healthcare setting. Z codes may be used as either a first listed principal diagnosis code in the inpatient setting or a secondary code depending on the circumstances of the encounter. Certain Z codes may only be used as first listed or principal diagnosis. Z codes indicate a reason for an encounter or provide additional information about a patient encounter. Z codes are not procedure codes. A corresponding procedure code must be accompanied with a Z code to describe any procedure performed. So we have some guidelines specifically about categories of Z codes. Number one, we have contact or exposure. Category Z20 indicates contact with and suspected exposure to communicable diseases. These codes are for patients who are suspected to have been exposed to a disease by close personal contact with an infected individual or are in an area where a disease is an epidemic. Category Z77, other contact with and suspected exposures to hazardous or exposures hazardous to health indicate contact with and suspected exposures to hazardous that are hazardous to their health. Contact or exposure codes may be used as a first listed code to explain an encounter for testing or more commonly as a secondary code to identify a potential risk. Inoculations and vaccinations. This is probably one of the most commonly used Z codes throughout the family practice and internal medicine spectrum, but is also used in certain other areas as well. Code Z23. This is used for encounters for inoculations and vaccinations. It indicates that a patient is being seen to receive a prophylactic inoculation against a disease. Procedure codes are required to identify the actual administration of the injection and the type or types of immunizations given. Code Z23 may be used as a secondary code if the inoculation is given as a routine part of preventive health care, such as a well baby visit. And number three, status codes. These indicate that a patient is either a carrier of a disease or has a sequelae or residual of a past disease or condition. This includes such things as the presence of a prosthetic or mechanical device resulting from past treatment. Examples of this could include a pacemaker, a stent, angioplasty status. This could be a fistula. There are many different devices that could be placed within a human body that would require a status code. A status code is informative because the status may affect the course of treatment and its outcome. A status code is distinct from a history code. History codes indicate that the patient no longer has the condition. For example, that could be a family history of a condition or even a personal history of a condition. For instance, if they are fully recovered and no longer being treated for any particular cancer, that could be a personal history of whatever that cancer is. A status code should not be used with a diagnosis code from one of the body system chapters if the diagnosis code includes the information provided by the status code. For example, Z94.1 for heart transplant status should not be used with a code from subcategory T86.2 for complications of heart transplant. The status code does not provide additional information. The complication code indicates that the patient is a heart transplant patient. For encounters for weaning from a mechanical ventilator, assign a code from subcategory J96.1 for chronic respiratory failure, followed by a code Z99.11 for dependence on respiratory or ventilator status. We have several Z status codes. So we have Z14. This is a genetic carrier status that indicates a person carries a gene associated with a particular disease, which may be passed to offspring who may develop that disease. The person does not have the disease and is not at risk of developing the disease. Z15, genetic susceptibility to a disease, indicates that a person has a gene that increases the risk of that person developing the disease. Codes from category Z15 should generally not be used as a principal or first listed code. If the patient has the condition to which he or she is susceptible, and that condition is the reason for the encounter, the code for the current condition should be sequenced first. If the patient is being seen for a follow up after completed treatment for this condition and the condition no longer exists, a follow up code should be sequenced first, followed by the appropriate personal history and genetic susceptibility codes. If the purpose of the encounter is genetic counseling associated with procreative management, code Z31.5 for encounter for genetic counseling should be assigned as the first listed code, followed by a code from category Z15, and additional codes should be assigned for any applicable family or personal history. Z16 is for resistance to antimicrobial drugs. This category indicates that a patient has a condition that is resistant to antimicrobial drug treatment. Sequence the infection code first. Z17 is for estrogen and other hormones and factors receptor status. Z18 is for retained foreign body fragments. Z19 is for hormone sensitivity malignancy status. Z21, which we previously covered in the HIV chapter, is for asymptomatic HIV infection status. This code indicates that a patient has tested positive for HIV but has manifested no signs or symptoms of the disease. Z22 is for a carrier of an infectious disease. Carrier status indicates that a person harbors the specific organisms of a disease without manifesting the symptoms and is capable of transmitting the infection. Z28.3 is for under immunization status. See section 1B14 for under immunization documentation by clinicians other than the patient's provider. Z33.1 pregnant state incidental. This code is a secondary code only for use when the pregnancy is in no way complicating the reason for the visit. Otherwise, a code from the obstetric chapter is required. Z66 for do not resuscitate. So, this is a diagnosis code that should be used when the decision to DNR is made. If the discussion happens within the note, you can assign Z66 for do not resuscitate. Z67 is when documenting the blood type. Z68 codes are for body mass index, and these are based on the BMI of the patient. And there are additional subcategories for the body mass number to indicate which Z68 code is the appropriate code to report. When documentation reflects fluctuating BMI, during the encounter for an associated reportable condition, assign a code for the most severe value. See Section 1B 14 for BMI documentation by clinicians other than the patient's provider. Z74.01 for bed confinement status. Z76.82 is for awaiting organ transplant status. Z78 is for other specified health status. Code Z78.1 for physical restraint status may be used when it is documented by a provider that a patient has been put in restraints during the current encounter. Please note that this code should not be reported when it is documented by the provider that a patient is temporarily restrained during a procedure. Z79 for long-term current drug therapy. Now, this is one of the most common diagnoses that I feel is missed when assigning diagnosis codes to an encounter. Z79 is used for patients that are using insulin drugs, hypoglycemic drugs, if they are on any other long-term drug, including anticoagulation therapy, aspirin, NSAIDs. There are multiple Z79 codes that can be assigned when the documentation provides that a patient has been on any specific long-term drug therapy. Z88 for allergy status to drugs, medicaments, and biological substances, except Z88.9 for allergy status to unspecified drugs, medicaments, and biological substances status. Z89 is for acquired absence of a limb. Z90 is for acquired absence of organs not elsewhere classified. And the others I'm not covering in today's session, but they include Z91, Z92.82, Z93, 94, 95, 96, 97, and Z98 and Z99. So now let's get into history of a little bit further. We have both history of personal and history of family conditions. So we have conditions such as Z85 for personal history of malignant neoplasm, Z86 for other certain diseases, Z87, Z91.4, 91.5, 91.81, and then we have some others, Z91.82, 85, and Z92. For family history of Z80, 81, 82, 83, and 84, all of these are listed on the screen. I'm not going to go through them individually, but you can also find these codes in the ICD 10 book in the Z code section. Now let's talk a little bit more about screening. Screening is when there is testing for a disease or disease precursors in seemingly well individuals so that early detection and treatment can be provided for those who test positive for the disease, such as a screening mammogram. The testing of a person to rule out or confirm a suspected diagnosis because that patient has some sign or symptom is a diagnostic examination, not a screening. In these cases, the sign or symptom is used to explain the reason for the test. A screening code may be a first listed code if the reason for the visit is specifically the screening exam. It may also be used as an additional code if the screening is done during an office visit for other health problems. A screening code is not necessary if the screening is inherent to a routine exam, such as a pap smear done during a routine pelvic examination. Should a condition be discovered during the screening, then a code for the condition may be assigned as an additional diagnosis. The Z code indicates that the screening exam is planned. A procedure code is required to confirm that the screening was performed. So, as seen on the screen, we have Z11, Z12, Z13, 13.9, and Z36 for our screening codes. So, next up on this page, we have observation codes. There are 3 observation Z code categories. They are used for use in very limited circumstances when a patient is being observed for a suspected condition that is ruled out. The observation codes are not for use in any injury or illness or signs or symptoms related to the suspected condition being present. In such cases, the diagnosis or symptom code is used with the corresponding external cause code. The observation codes are primarily to be used as principal first listed diagnosis. An observation code may be assigned as a secondary diagnosis code when the patient is being observed for a condition that is ruled out and is unrelated to the principal or first listed diagnosis. Also, when the principal diagnosis is required to be a code from category Z38 for live-born infants according to place of birth and type of delivery, then a code from category Z05 encounter for observation and evaluation of a newborn for suspected diseases and conditions ruled out is sequenced after the Z38 code. This was also covered in another session that we have released. If you want additional information on that, please go back and check out that session. Additional codes may be used in addition to observation codes, but only if they are unrelated to the suspected condition being observed. Codes from subcategory Z03.7 for the encounter for suspected maternal and fetal conditions ruled out may either be used as a first listed or as an additional code assignment depending on the case. They are for use in very limited circumstances on the maternal record when an encounter is for suspected maternal or fetal condition that is ruled out during the encounter. For example, a maternal or fetal condition may be suspected due to an abnormal test result. These codes should not be used when the condition is confirmed. In those cases, the confirmed condition should be coded. In addition, these codes are not for use if an illness or any signs or symptoms related to the suspected condition or problem are present. In such cases, we want to make sure that we code the diagnosis or symptom code. Additional codes may be used in addition to code from subcategory Z03.7, but only if they are unrelated to the suspected condition being evaluated. For additional information, you can check out 1C21 for screening. There are also observation category codes Z03, Z04, and Z05, and these are for different encounters, including medical observation for suspected diseases of conditions being ruled out, examination and observation for other reasons, except Z04.9 for encounter for examination and observation for an unspecified reason. And lastly, for our observation categories, we have Z05 for the encounter for observation and evaluation of a newborn for suspected diseases and conditions being ruled out. Lastly, on this slide, we have aftercare codes. Aftercare visit codes cover situations when the initial treatment of a disease has been performed and the patient requires continued care during the healing or recovery phase or for long-term consequences of the disease. The aftercare Z code should not be used if the treatment is directed at a current acute disease. The diagnosis code is to be used in these cases. The aftercare Z codes should also not be used for aftercare for injuries. For aftercare for an injury, assign the acute injury code with the appropriate 7th character for subsequent encounter. The aftercare codes are generally first listed to explain the specific reason for the encounter. An aftercare code may be reported as an additional code when a specific type of aftercare is provided in addition to the reason for the encounter. An example of this would be the closure of a colostomy during an encounter for treatment of another condition. Aftercare codes should be used in conjunction with other aftercare codes or diagnosis codes to provide better detail on the specifics of an aftercare encounter visit, unless otherwise directed by the classification. The sequencing of multiple aftercare codes depend on the circumstances of the encounter. There are certain aftercare Z code categories that need to be a secondary diagnosis code to describe the resolving condition or sequelae. For others, the condition is included in the code title. Additional Z code aftercare category terms including fitting and adjustment and attention to artificial openings. Status Z codes may be used with aftercare Z codes to indicate the nature of the aftercare. For example, code Z95.1 for presence of an aortocoronary bypass graft or a cabbage is the other term for that, may be used with a code Z48.812 for encounter for surgical aftercare following surgery on the circulatory system. This is to indicate the surgery for which the aftercare is being performed. A status code should not be used when an aftercare code indicates the type of status, such as using Z43.0 encounter for attention to tracheostomy with code Z93.0 tracheostomy status. Aftercare codes are generally found in the following categories: Z42, Z43, Z44, Z45, 46, 47, 48, 49, and Z51, all of which are listed on the screen, so I'm not going to go through them individually. Next up for this slide, we have follow-up. The follow-up codes are used to explain continuing surveillance following completed treatment of a disease, condition, or injury. They imply that the condition has been fully treated and no longer exists. They should not be confused with aftercare codes or injury codes with a seventh character for subsequent encounter that explain an ongoing care of a healing condition or sequelae. Follow-up codes may be used in conjunction with history codes to provide the full picture of the healed condition and its treatment. The follow-up code is sequenced first, followed by the history code. A follow-up code may be used to explain multiple visits. Should a condition be found to have recurred on the follow-up visit, then the diagnosis code for the condition should be assigned in place of the follow-up code. The follow-up code categories we have are Z08, Z09, and Z39. We also have code Z08, encounter for follow-up examination after completed treatment for malignant neoplasm. Z09, encounter for follow-up examination after completed treatment for conditions other than a malignant neoplasm, may be assigned following any type of completed treatment modality, including both medical and surgical treatments. Next up, we have donor. So for codes in category Z52, donors of organs and tissues are used for living individuals who are donating blood or other body tissue. These codes are for individuals donating for others as well as self-donations. They are not used to identify cadaveric donations. And for anyone not familiar, that would be for a patient that has been deceased, is for a cadaveric donation. Number 10, for counseling. Counseling Z codes are used when a patient or family member receives assistance in the aftermath of an illness or injury, or when support is required in coping with family or social problems. The counseling Z code categories are as follows: Z30.0, Z31.5, 31.6, 32.2, 32.3, Z69, Z70, Z71, which includes code Z71.84, for encounter for healing counseling related to travel, is to be used for health risk and safety counseling for future travel purposes. So when you use Z71.84, that's usually because a patient is going out of the country or in another area that could have a higher risk of contracting certain diseases. Usually they'll give them a certain round of antibiotics to use as a prophylactic measure. Z71.85 for the encounter for immunization safety counseling is to be used for counseling of a patient or caregiver regarding the safety of a vaccination. This code should not be used for the provision of general information regarding risk and potential side effects during routine encounters for the administration of vaccinations. Z71.87 for encounter for pediatric to adult transition counseling should be assigned when pediatric to adult transition counseling is the sole reason for the encounter, or when the counseling is provided in addition to other services such as treatment of a chronic condition. If both transition counseling and treatment of a medical condition are provided during the same encounter, the code or codes for the medical condition or conditions treated and a code from Z71.87 should be assigned with sequencing depending on the circumstances of the encounter. And lastly, for this section, Z76.81 for expectant mother pre-birth pediatrician visit. For encounters for obstetrical or reproductive services, see Section 1C15 for pregnancy, childbirth, and the puerperium for further instruction for use of these codes. Again, we did cover this in a previous session, so please make sure you go back and check that particular session out. Z codes for pregnancy are for use in those circumstances when none of the problems or complications included in the codes from the obstetrics chapter exist. For example, a routine prenatal visit or postpartum care. Codes in category Z34 for encounter for supervision of a normal pregnancy are always first listed and are not to be used with any other code from the OB chapter. Codes in category Z3A for weeks of gestation may be assigned to provide additional information about the pregnancy. Z3A codes should not be assigned for pregnancies with abortive outcomes. Categories O00 through O08, elective termination of pregnancy. Code Z33.2, nor for postpartum conditions, as category Z3A is not applicable to these conditions. The date of the admission should be used to determine weeks of gestation for inpatient admissions that encompass more than one gestational week. The outcome of delivery, category Z37, should be included on all maternal delivery records. It is always a secondary code. Codes in category Z37 should not be used on the newborn record. Z codes for family planning for contraceptive or procreative management and counseling should be included on an obstetric record either during the pregnancy or postpartum stage if applicable. Codes Z30, Z31, Z32.2, 32.3, 33, 34, 36, Z3A, Z37, Z39, and Z76.81 are all listed in your book if you would like additional information on those codes. Now, for routine and administrative examinations. The Z codes allow for the description of encounters for routine examinations, such as a general checkup or examinations for administrative purposes, such as a pre employment physical. The codes are not to be used if the examination is for diagnosis of suspected conditions or for treatment purposes. In such cases, the diagnosis code is to be used. During a routine exam, should a diagnosis or condition be discovered, it should be coded as an additional diagnosis. Pre-existing and chronic conditions and history codes may also be included as additional codes as long as the examination is for administrative purposes and not focused on a particular condition. Some of the codes for routine health examinations distinguish between with and without abnormal findings. Code assignment depends on the information that is known at the time of the encounter that is being coded. For example, if no abnormal findings were found during the examination, but the encounter is being coded before the test results are back, it is acceptable to assign a code without abnormal findings. When assigning a code for with abnormal findings, additional code or codes should be assigned to identify the specific abnormal finding or findings. Preoperative examination and pre-procedural laboratory examination Z codes are for use only in those situations when a patient is being cleared for a procedure or surgery and no treatment is given. So, this is very common for certain encounters where, say, for instance, a patient is being sent to a cardiologist to be released under heart conditions for a separate surgery, such as like an orthopedic surgery, where the patient already has pre existing heart conditions and they have to know that they're healthy enough for surgery. So some of the Z codes that we see pretty often, you have Z00, which is for your general examinations without complaint, suspected, or reported diagnosis. These are usually your yearly physicals, your well woman exams, or your well child exams. Z01 falls into the same category. Z02 is an encounter for an administrative examination. So that could be like the pre employment exam or something such as that. We also have Z02 for, or excuse me, except for Z02.9, encounter for administrative exams unspecified. Z32.0 for encounter for pregnancy tests. So, this would be a case where the patient came in and requested that there was a possibility of pregnancy, or the provider feels that it is necessary to run a pregnancy test for other reasons. We also have miscellaneous Z codes, and I will not cover all of these. We're just going to go over a few. So, for prophylactic organ removal. So, for encounters specifically for prophylactic removal of an organ, such as prophylactic removal of breast due to a genetic susceptibility to cancer or a family history of cancer, the principal or first listed code should be a code from subcategory Z40.0 for encounter for prophylactic surgery for risk factors related to malignant neoplasms, or subcategory Z40.8 for encounter for other prophylactic surgery. If applicable, assign additional coder codes to identify any additional risk factor, such as genetic susceptibility or family history. If the patient has a malignancy of one site and is having prophylactic removal at another site to prevent either a new primary malignancy or metastatic disease, a code for the malignancy should also be assigned in addition to a code from subcategory Z40.0 for encounter for prophylactic surgery for risk factors related to malignant neoplasms. A Z40.0 code should not be assigned if the patient is having organ removal for treatment of a malignancy, such as the removal of a testes for treatment of prostate cancer. Some of the additional categories or subcategories are also listed in the book if you would like additional information on those. See section 1B14 for Z55 through Z65 persons with potential health hazards related to socioeconomic and physiosocial circumstances documented by clinicians other than the patient's provider. Last up for this slide, we have non-specific Z codes. So there are certain Z codes that are so non-specific or potentially redundant with other codes in the classification that there can be little justification for their use in the inpatient setting. Their use in the outpatient setting should be limited to those instances when there is no further documentation to permit more precise coding. Otherwise, any sign or symptom or any other reason for the visit that is captured in another code should be used. So, for example, these are ones that you are just not going to see on a regular basis. So, encounter for administrative exams, unspecified, examination and observation unspecified, screening unspecified, purposes other than remedying health state, donor of unspecified organ or tissue, personal history of other mental or behavioral disorders, allergy status to unspecified drugs, or personal history of contraception. So, some of these we've already talked about, but this is specific to Z codes that may only be the principal or first listed diagnosis. So if you remember a minute ago, we did cover our Z01 or Z00010204 and 33.2, but just as a reminder, these are first listed or principal diagnosis codes only, meaning they should not be secondary codes. For newborns and infants, see Section 1C16 for newborn perinatal guidelines for further instruction on the use of these codes. And last for this slide, we have social determinants of health. Social determinants of health, otherwise known as SDOH, codes that are describing social problems, conditions, or risk factors that influence a patient's health should be assigned when this information is documented in the patient's medical record. Assign as many SDOH codes that are necessary to describe all social problems, conditions, or risk factors documented during the current episode of care. For example, a patient who lives alone may suffer from an acute injury temporarily impacting their ability to perform routine activities of daily living. When documented as such, this would support code assignment Z60.2 for problems related to living alone. However, merely living alone without documentation of a risk or unmet need for assistance at home would not support assignment of a code. Z60.2 documentation by a clinician or patient reported information that is signed off by a clinician that the patient expressed concerns with access and availability of food would support code assignment Z59.41 for food insecurity. Similarly, medical record documentation indicating a patient is experiencing homelessness would support an assignment of code from subcategory Z59.0 for homelessness. For social determinants of health classified to Chapter 21, such as information found in categories Z55 through Z50 or through Z65, persons with potential health hazards related to socioeconomic and physiosocial circumstances or psychosocial circumstances, code assignment may be based on medical record documentation from clinicians involved in the care of a patient who are not the patient's provider, since this information represents social information rather than medical diagnoses. For example, coding professionals may utilize documentation for social information from social workers, community health workers, case managers, or nurses if their documentation is included in the official medical record. Patient self reported documentation may be used to assign codes for social determinants of health as long as the patient's self reported information is signed off by and incorporated in the medical record by either a clinician or provider. Social determinants of health codes are located primarily in these Z code categories. So Z55 through Z65 is listed in your book for additional information on these codes. See section 1B14 for documentation by clinicians other than the patient's provider. That closes us up for chapter 21. Our last chapter And sadly, the last chapter for our ICD 10 chapter specific guideline sessions is chapter 22 for coding for special purposes, U00 through U85. So, we do have several guidelines in this chapter that we want to talk about. More specifically, the U codes for special purposes are newer to the guidelines than some of the other chapters. U07.0, vaping related disorder. Want to see section 1C 10.E for vaping related disorders. For U07.1, COVID 19, you'll want to see section 1C 1.G.1 for COVID 19 infection. U09.9 for post-COVID condition unspecified, you'll want to see section 1C1.G.1.M. So for section 2, selection of a principal diagnosis. The circumstances of inpatient admission always govern the selection of principal diagnosis. The principal diagnosis is defined in the Uniform Hospital Discharge Dataset, or UHDDS, as that condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. The UHDDS definitions are used by hospitals to report inpatient data elements in a standardized manner. These data elements and their definitions can be found in the July 31st, 1985 Federal Register, Volume 50, number 147, page 31038 through 40. Since that time, the application of the UHDDS definitions has been expanded to include all non-outpatient settings, including acute care, short-term, long-term care, and psychiatric hospitals, home health agencies, rehab facilities, nursing homes, etc. The UHDDS definitions also apply to hospice services for all levels of care. In determining principal diagnosis, coding conventions in the ICD-10 CM, the tabular list and alphabetic index take precedence over these official coding guidelines. See section 1A for conventions for the ICD-10 CM. The importance of consistent, complete documentation in the medical record cannot be overemphasized. Without such documentation, the application of all coding guidelines is as difficult, if not impossible, task. So, codes for symptoms, signs, and ill-defined conditions. If you want additional information on this, make sure that you see Chapter 18. For two or more interrelated conditions, each potentially meeting the definition for principal diagnosis, when there are two or more interrelated conditions, such as diseases in the same ICD-10 chapter or manifestations characteristically associated with a certain disease, potentially meeting the definition of principal diagnosis, either condition may be sequenced first unless the circumstances of the admission, the therapy provided, the tabular list, or the alphabetic index indicate otherwise. When two or more diagnoses that equally meet the definition for principal diagnosis. In the unusual instance when two or more diagnoses equally meet the criteria for principal diagnosis as determined by the circumstances of admission, diagnostic workup and or therapy provided, and the alphabetic index, tabular list, or another coding guideline does not provide sequencing direction, any one of the diagnoses may be sequenced first. When two or more comparative or contrasting conditions exist, this is a rare instance when this can happen when both are documented as either or similar terminology. They are coded as if the diagnoses were confirmed and the diagnoses are sequenced according to the circumstances of the admission. If no further determination can be made as to which diagnosis should be principal, either diagnosis could be sequenced first. When a symptom or symptoms followed by contrasting comparative diagnoses, this was deleted as effective October 1st, 2014. For original treatment plan not carried out, sequence as the principal diagnosis the condition which, after the study, occasioned the admission to the hospital, even though treatment may not have been carried out due to unforeseen circumstances. When the admission is for treatment of a complication resulting from surgery or other medical care, the complication code is sequenced as the principal diagnosis. If the complication is classified to T80 through T88 series and the code lacks the necessary specificity in describing the complication, an additional code for the specific complication should be assigned. For uncertain diagnosis, if the diagnosis is documented at the time of discharge and is qualified as probable, suspected, likely, questionable, possible, still to be ruled out, compatible with, consistent with, or other similar terms indicating uncertainty, code the condition as if it existed or was established. The basis for these guidelines are diagnostic workup, arrangements for further workup or observation, and initial therapeutic approach that correspond most closely with the established diagnosis. I want to make a very clear notation here that this guideline is applicable only to inpatient admissions to short-term, acute, long-term care, and psychiatric hospitals. Admission from observation units. So, admission following medical observation. When a patient is admitted to an observation unit for a medical condition, which either worsens or does not improve, and is subsequently admitted as an inpatient of the same hospital for the same medical condition, the principal diagnosis would be the medical condition which led to the hospital admission. When there is admission following postoperative observation, when a patient is admitted to observation unit to monitor a condition or complication that develops following outpatient surgery and then is subsequently admitted as an inpatient of the same hospital, hospitals should apply the Uniform Hospital Discharge Dataset, or UHDDS, definition of principal diagnosis as the condition established after the study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. For admission from outpatient surgery, when the patient receives surgery in the hospital's outpatient surgery department and is subsequently admitted for continuing inpatient care at the same hospital, the following guidelines should be followed in selecting the principal diagnosis for the inpatient admission. If the reason for the inpatient admission is a complication, assign the complication as the principal diagnosis. If no complication or other condition is documented as the reason for the inpatient admission, assign the reason for the outpatient surgery as the principal diagnosis. If the reason for the inpatient admission is another condition unrelated to the surgery, assign the unrelated condition as the principal diagnosis. For admissions or encounters for rehabilitation, when the purpose for the admission or encounter is rehabilitation, sequence first the code for the condition for which the service is being performed. For example, For an admission or encounter for rehabilitation for right-sided dominant hemiplegia following a cerebrovascular infarction, report code I69.351 for hemiplegia and hemiparesis following cerebral infarction affecting the right dominant side as the first listed or principal diagnosis. If the condition for which the rehabilitation service is provided is no longer present, report the appropriate aftercare code as the first listed or principal diagnosis unless the rehabilitation service is being provided following an injury. For rehabilitative services following active treatment of an injury, assign the injury code for the appropriate seventh character for subsequent encounter as the first listed or principal diagnosis. For example, if a patient with severe degenerative osteoarthritis of the hip underwent hip replacement and the current encounter or admission is for rehabilitation, report code Z47.1 aftercare following joint replacement surgery as the first listed or principal diagnosis. If the patient requires rehabilitation post hip replacement for right intratrochanteric femur fracture, report code S72.141D for displaced intratrochanteric fracture of right femur, subsequent encounter for closed fracture with routine healing as the first listed or principal diagnosis. For more information on this, you can see section 1C21.C.7 for factors influencing health states and contact with health services aftercare, or see section 1C19.A for additional information about the seventh characters for injury codes. For section 3, reporting additional diagnoses. There are general rules for this section. For reporting purposes, the definition for other diagnoses is interpreted as additional clinically significant conditions that affect the patient's care in terms of requiring clinical evaluation, therapeutic treatment, diagnostic procedures, extended length of hospital stay, or increased nursing care and or monitoring. The UHDDS item number 11B defines other diagnoses as all conditions that coexist at the time of admission that develop subsequently or that affect the treatment received and or the length of stay. Diagnoses that relate to an earlier episode which have no bearing on the current hospital stay are to be excluded. The UHDDS definitions apply to inpatients in acute care, short-term, long-term care, and psychiatric hospital settings. The UHDDS definitions are used by acute care, short-term hospitals to report inpatient data elements in standardized manner. These data elements and their definitions can be found in the July 31st, 1985 Federal Register, Volume 50, number 147, pages 31038 through 40. Since that time, the application of the UHDDS definitions have been expanded to include all non-outpatient settings, including those we have previously mentioned. The following guidelines are to be applied in designating other diagnoses when neither the alphabetic index nor the tabular list in the ICD-10-CM provide direction. The listing of the diagnoses in the patient record is the responsibility of the provider. For previous conditions, if the provider has included a diagnosis in the final diagnostic statement, such as the discharge summary or face sheet, it should ordinarily be coded. Some providers include the diagnostic statement, resolved conditions or diagnoses, and status post procedures from previous admissions that have no bearing on the current stay. Such conditions are not to be reported and only coded if required by hospital policy. However, history codes, categories Z80 through Z87, may be used as secondary codes if the historical condition or family history has an impact on current care or influences treatment. Abnormal findings such as laboratory, x-ray, pathologic, and or diagnostic results are not coded and reported unless the provider indicates their clinical significance. If the findings are outside the normal range and the provider has ordered other tests to evaluate the conditions or prescribe treatment, it is appropriate to assign the provider to ask the provider whether the abnormal findings should be added. Just a note, this differs from the coding practices in outpatient setting for coding encounters for diagnostic tests that have been interpreted by a provider. Uncertain diagnosis. If the diagnosis documented at the time of discharge, again, we talked about this earlier, probable, suspected, or other terms such as that, just remember that in the inpatient setting that these can be used. For Section 4, Diagnostic Coding and Reporting Guidelines for Outpatient Services. These coding guidelines for outpatient diagnoses have been approved for use by hospitals and providers in coding and reporting hospital-based outpatient services and provider-based office visits. Guidelines in Section 1, conventions, general coding guidelines, and chapter-specific guidelines should also be applied for outpatient services and office visits. Information about the use of certain abbreviations, punctuation, symbols, and other conventions used in the ICD-10 tabular list, such as code numbers and titles, can be found in Section IA of those guidelines. Under the conventions used in the tabular list, Section 1B contains general guidelines that apply to the entire classification. Section 1C contains chapter-specific guidelines that correspond to chapters as they are arranged in the classification. Information about the correct sequencing to use in finding a code is described in Section 1. The terms encounter and visit are often used interchangeably in describing outpatient services, contacts, and therefore appear together in these guidelines without distinguishing one from another. Though the conventions and general guidelines apply to all settings, coding guidelines for outpatient and provider reporting of diagnoses will vary in a number of instances from those for inpatient diagnoses, recognizing that the Uniform Hospital Discharge Dataset, or UHDDS, definition of principal diagnosis does not apply to hospital-based outpatient services and provider-based office visits. Coding guidelines for inconclusive diagnoses, such as probable, suspected, rule out, etc., were developed for inpatient reporting and do not apply to outpatients. For selection of first listed conditions. In the outpatient setting, the term first listed diagnosis is used in lieu of principal diagnosis. In determining the first listed diagnosis, the coding conventions of the ICD-10-CM, as well as the general and disease-specific guidelines, take precedence over outpatient guidelines. Diagnoses often are not established at the time of the initial encounter or visit, and it may take 2 or more visits before the diagnosis is confirmed. The most critical rule involves beginning the search for the correct code assignment through the alphabetic index. Never begin searching initially in the tabular list, as this will lead to coding errors. Okay, so for outpatient surgery, when a patient presents for outpatient surgery, such as same day surgery, code the reason for the surgery as listed as the first listed diagnosis or reason for the encounter, even if the surgery is not performed due to contraindication. For observation stay, when a patient is admitted for observation for a medical condition, assign a code for the medical condition as the first listed diagnosis. When a patient presents for outpatient surgery and develops conditions requiring admission to observation, code the reason for the surgery as the first listed or first reported diagnosis or the reason for the encounter, followed by the codes for the complications as secondary diagnoses. Codes from A00 through T88.9, Z00 through Z99, and U00 through U85 must be used to identify diagnoses, symptoms, conditions, problems, complaints, or other reasons for the encounter or visit. Accurate reporting of the ICD-10 CM diagnosis codes, the documentation should describe the patient's condition using terminology which includes specific diagnoses as well as symptoms, problems, or reasons for the encounter. There are ICD-10 CM codes to describe all of these. Codes that describe signs and symptoms as opposed to diagnoses are acceptable for reporting purposes when a diagnosis has not been established or confirmed by the provider. Chapter 18 of the ICD-10 CM for symptoms, signs, and abnormal clinical and laboratory findings, not elsewhere classified to codes R00 through R99, contain many but not all codes for symptoms. Encounters for circumstances other than a disease or injury. The factors influencing health status and contact with health services, code Z00 through Z99, are provided to deal with occasions when circumstances other than a disease or injury are recorded as diagnoses or problems. And you can see section IC21 for factors influencing health status and contact with health services. For level of detail in coding, we have three different major guidelines. We have ICD-10 codes with a third, fourth, fifth, sixth, or seventh character. Remember that when these additional characters are required, it must be done at the greatest specificity and it must include all required characters to be a complete code. We also want to make sure that we are querying our provider if we show that it supports a higher specificity, but the provider has not documented it appropriately. For ICD-10 CM codes for the diagnosis, condition, problem, or other reason for the encounter, want to make sure that we list these in order for what is chiefly responsible for the services being provided. You'll want to list additional codes that describe any coexisting conditions. And in some cases, the first listed diagnosis may be a symptom when a diagnosis has not been established or confirmed by the provider. Again, I'm not going to repeat it, but we know that for uncertain diagnoses, these are not allowed in the outpatient or office setting. For chronic diseases treated on an ongoing basis, these may be coded in reporting as many times as the patient receives treatment and care for these conditions. We want to make sure that we code all documented conditions that coexist. Do not code conditions that were previously treated and no longer exist. However, history codes from Z80 through 87 may be used as secondary codes if the historical condition or family history has an impact on the current care or influences treatment. Patients receiving diagnostic services only. Sequence first the diagnosis, condition, or problem, or other reason for the encounter or visit shown in the medical record to be chiefly responsible for the outpatient services provided during the encounter or visit. Codes for other diagnoses, such as chronic conditions, may be sequenced as additional diagnoses. For patients receiving therapeutic services only, sequence first the diagnosis, condition, or problem or other reason for the encounter or visit shown in the medical record to be chiefly responsible for the outpatient services provided during that encounter or visit. And a lot of these are repetitive, but remember, we still have to make sure that we're following the guidelines. So if you ever question any of these, just make sure you reference back to the guidelines to ensure that you are putting these in the appropriate order and coding these to the highest specificity. When we are coding for patients receiving preoperative evaluations only, sequence first a code from subcategory Z01.81 for encounter for pre-procedural examinations to describe the pre-op consultation. Again, we mentioned this earlier. For instance, if you're being referred to your cardiologist for pre-existing heart conditions for, say, an orthopedic procedure, they would use Z01.810 as the first listed diagnosis as a pre-op consultation for cardiovascular conditions. For ambulatory surgery, code the diagnosis for which the surgery was performed. If the postoperative diagnosis is known to be different from the preoperative diagnosis at the time of the diagnosis is confirmed, select the postoperative diagnosis for coding since it is the most definitive. For routine outpatient prenatal visits, see section 1C15 for routine outpatient prenatal visits. For encounters for general medical examinations without abnormal findings, we previously covered this in the chapter prior to this for your Z000, Z00.12, and other diagnosis codes. If there is an abnormal finding, a secondary code for the abnormal finding should also be coded. Last up for this section, encounters for routine health screenings. See section 1C21 for factors influencing health status and contact with health services screening. Okay, everybody, that's going to close us out for this series. I hope everyone has enjoyed all of the sessions for the ICD-10 chapter-specific coding guidelines. If you would like to leave us a review, please do so. I would love your feedback. Make sure you give us a thumbs up. Subscribe to the channel, hit that bell to be notified every time we post a new video. Come check us out over on Facebook and LinkedIn. We have pages on both of those social media platforms as well. And we look forward to seeing you in the next series. Hope you all have a great day.